Welcome back to the deep dive. Today we're tackling something absolutely fundamental, really core to surgical practice and just human biology itself. Wound healing and tissue repair.
It's a huge topic.
It really is. And
Yeah.
we're not just talking about, putting a plaster on a cut. This is about the incredibly complex biological symphony that kicks off the second you get injured.
Right. A cascade of events.
Exactly. And why this specific deep dive now? Well, because every single surgical cut, every injury, every burn, it all relies on this process working predictably. But there's a catch, isn't there?
There is. What we normally see in adults, the standard outcome, is fibrosis and scar formation.
Yeah, the scar.
And while we kind of accept that on the skin, that same scarring process in, say, your heart after an attack or in your liver, well, that leads to major tissue dysfunction. It's actually a failure state, in a way.
A failure state. That's a stark way to put it, especially when you contrast it with fetal healing.
Absolutely.
Yeah.
That's the really fascinating part driving so much research. Early fetal tissue, it can heal without that fibrosis. It actually regenerates. Truly scarless healing.
Wow. So nature can do it perfectly.
Yeah.
The scar is just maybe a faster, more robust, but less perfect mechanism we default to as adults.
That's a good way to think about it. Quick fix that prioritizes closing the gap over perfect restoration.
Okay. So our mission today is to really unpack all of this. We're going deep into the physiology, the clinical classification systems, the management frameworks, pulling it all straight from the essential surgical texts like Bailey and Love.
The aim is a complete picture for you, something solid for revision, but also really applicable in practice.
Let's get into it.
Right. So if you want to manage wounds well, you absolutely have to know the underlying process inside out. Traditionally, we talk about 3 overlapping phases, but really, you have to include the very first step, so 4 phases in total.
Starting with the immediate response, hemostasis.
Hemostasis, exactly. Instantaneous. The moment a blood vessel is broken, 2 things happen almost simultaneously. First, the vessel clamps down vasoconstriction to try and limit the bleeding.
Makes sense.
And second, that damage exposes the stuff underneath the vessel, lining the subendothelial matrix. And that exposure is the trigger
For the platelets.
for the platelets. They're the first responders, really. They stick to that exposed matrix, they activate, they clump together aggregation, forming that initial plug.
The physical barrier. But they do more than just block the hole, don't they? They're like little signal flares.
Oh, absolutely. That's almost the more critical part. When they activate and aggregate, they release the contents of their alpha granules. We're talking hundreds of different proteins. It's a massive chemical signal burst.
A cytokine and growth factor arsenal, as the book puts it.
That's a perfect description. And these signals basically dictate everything that happens next. They call in the other cells. They tell them what to build.
So let's name the key players here, the ones you really need to know.
Okay, the big ones. You got TGF-β, transforming growth factor beta. Hugely important, especially later on for making matrix and, well, fibrosis.
Okay.
Then PDGF, platelet-derived growth factor. Think of that as the main recruiter, pulling in fibroblasts and monocytes.
Got it.
Then you have FGF and EGF, fibroblast and epidermal growth factors. They're all about stimulating cells to divide and grow, especially for rebuilding the skin surface.
And the last one, crucial for blood supply.
VEGF.
Yeah.
Vascular endothelial growth factor. That's the master switch for angiogenesis, building new blood vessels. Absolutely vital for bringing oxygen and nutrients into the healing area.
Okay, so platelets form the plug and send out the signals. What about the coagulation cascade? How does that fit in? Is that separate?
It happens right alongside, triggered by tissue factor released from the injured cells. It's a complex chain reaction, but the end result is generating thrombin.
And thrombin does what?
Thrombin converts fibrinogen, which is soluble, into fibrin, which is insoluble. Fibrin forms these long, sticky strands that weave through and reinforce that initial platelet plug. Makes it much stronger.
Ah, so it's like adding rebar to concrete.
Exactly like that. This fibrin clot isn't just a plug, it's a stable, 3-dimensional scaffold. It's the framework that all the other cells will crawl into and move along during the next phases. #2. Inflammation, days 1 to 3.
Right, bleeding stopped, scaffold built. Now the cleanup crew arrives, inflammation phase. Typically days 1 to 3.
That's the window. The early part, say the first day or 2, is all about the neutrophils. Polymorphonuclear leukocytes, technically.
The shock troops.
Perfect analogy. They swarm into the wound using that fibrin scaffold we just talked about. Their main job, kill bacteria, prevent infection. Absolutely critical, especially in contaminated wounds.
And what helps them get there so fast?
Things like histamine and serotonin, released by the platelets in damaged tissue. They make the blood vessels nearby more permeable, more leaky.
So the neutrophils can just flood out into the tissue.
Exactly. Allows for that rapid influx.
Okay, so neutrophils dominate early, but then the cellular picture changes.
It does. Around day 2 or 3, the macrophages start arriving in big numbers. They actually start as monocytes in the blood, then differentiate into macrophages in the tissue.
And these guys are the real power players, aren't they? Doing two jobs at once.
They really are. Dual function. First, they're incredible phagocytes, like microscopic vacuum cleaners. They eat up the dead neutrophils, the fibrin debris, any remaining bacteria, damaged tissue. They debride the wound using enzymes.
Cleaning everything up.
But then, crucially, they switch roles. They become the primary producers of more growth factors and cytokines, like the PDGF and TGF-β we mentioned.
The same ones the platelets release?
Many of the same ones, yes, and others too. They basically orchestrate the transition out of inflammation into the next phase, proliferation. They're telling the fibroblasts to come in and start building.
Wow. So the cleanup crew also calls in the construction crew. Very efficient.
It's elegant biology.
And clinically, this whole inflammatory phase, this is what gives us those classic signs we learn, right? The redness, swelling, heat, pain.
Absolutely. Rubor, tumor, calor, dolor. That's the visible manifestation of all this cellular activity and vascular change. It's the body's defense system in action. #3, proliferation. Day 3 to 2 to 4 weeks.
Okay, so the macrophages have signaled the shift. We move into the proliferative phase. Starting around day 3, maybe lasting 2, 3, even 4 weeks. This is intense construction time, filling the gap.
And the main builders are the fibroblasts.
They're central. Guided by signals like PDGF, fibroblasts migrate into the womb bed, and they just start churning out extracellular matrix components.
What kind of components?
Initially, ground substance, that's things like glycosaminoglycans, proteoglycans, gives it bulk, hydration, and then critically, collagen, lots of it.
And at the same time, new blood vessels are forming, angiogenesis.
Yep, rapid angiogenesis is happening, creating capillary loops. And the skin surface is being rebuilt, re-epithelialization. Epithelial cells migrate across the wound. And all this activity, this is what we see as granulation tissue.
Exactly. If you look into an open wound healing well, you'll see that pinky red, kind of bumpy granular tissue filling the base. That's granulation tissue. It's packed with new capillaries, hence the color, and full of active fibroblasts.
Okay. And as those fibroblasts pump out collagen, the wound starts getting stronger.
It starts to gain tensile strength, yes. Slowly at first. And another really important thing happens here. Some fibroblasts change. They differentiate into myofibroblasts. Precisely. They develop contractile filaments, a bit like smooth muscle cells, and these myofibroblasts grab onto the wound edges and literally pull them together.
Wound contraction.
Exactly. It's a powerful mechanism that significantly shrinks the size of the defect that needs filling. Really important, especially in larger wounds left to heal open. #4. Remodeling, 2-3 weeks to a year or more.
So proliferation fills the hole with granulation tissue and starts the strength game. But it's not the final product, is it? It's kind of rough and ready.
Very much so. The collagen laid down is messy, disorganized. The remodeling phase is all about refining that structure, making it stronger, more organized. And this takes time. Starts around week 2 or 3, but can go on for a year, even longer.
And the key change is the type of collagen.
That's the absolute core of it. During proliferation, the dominant collagen is type 3. Think of it as quick-setting cement. It fills the gap fast, but it's not that strong.
Okay.
Remodeling is about gradually breaking down that type 3 collagen and replacing it with type I collagen. Type I is the main structural collagen in normal skin. It's much stronger, more durable.
Like replacing the quickset cement with high-strength, reinforced concrete.
Perfect analogy. This switch is managed by enzymes, matrix metalloproteinases, or MMPs.
And is there a target ratio the body's aiming for?
Yeah, it's trying to get back towards the normal skin ratio of type 1 to type 3, which is roughly 4:1. And it's not just the type, it's the organization. The type I fibers cross-link with each other and align themselves along the lines of stress.
That alignment must be key for strength.
Hugely. That organization is what really boosts the tensile strength. But here's the crucial number to remember. That strength gain peaks around 12 weeks after the injury.
12 weeks, okay. 3 months.
But even at its absolute maximum, the healed scar only ever reaches about 80% of the strength of the original uninjured skin.
Only 80%, even after a year or more of remodeling.
Only 80%. That's the ceiling. It's an inherent weakness. something you always have to factor in, especially when dealing with tissues under high load. That scar is never quite as good as the original.
That 80% figure really sticks with you, a fundamental limitation.
Okay, so we've covered the basics in skin, but other tissues like bone, nerve, tendon, they have their own unique challenges and repair mechanisms. They don't just form a simple fiber scar.
Right, let's start with bone. It's kind of special because it can actually regenerate, right? Replace like with like?
Often, yes. It still goes through those same general phases, hematoma, inflammation, proliferation, remodeling, but the proliferation part is about making new bone, not just fibrous tissue. And how it does that depends mainly on stability.
Stability of the fracture.
Exactly. If a fracture is treated non-operatively, or maybe with something that allows a little movement like a cast or some intramedullary nails, it usually heals by indirect or secondary healing.
Okay, what does that involve?
The initial big blood clot, the hematoma, organizes. Then, instead of just fibroblasts, you get cartilage-forming cells moving in, creating a soft callus made of fibrocartilage. Can't really see this well on X-ray initially.
Soft callus. Okay.
Then, that soft callus gets replaced by bone. This is endochondral ossification bone forming on a cartilage template. This creates the hard callus, which is visible on X-ray. It bridges the gap. Finally, that hard callus remodels over months or years into strong lamellar bone, trying to restore the original shape.
That's the callus we typically think of with fracture healing, but modern surgery often aims for something different, with plates and screws.
Right. That's aiming for primary or direct healing. This happens only if you achieve absolute stability, meaning virtually zero movement at the fracture site, and the bone ends are perfectly touching or very, very close.
So rigid fixation is key.
Absolutely critical. If you get that, bone can form directly across the fracture line without forming that intermediate cartilage callus. It's intramembranous ossification. New bone grows straight across.
Faster, better.
Potentially faster union, and it's the goal of ORF, open reduction, and internal fixation. But there's a risk. If you don't get that perfect stability, or if there's even a small gap, say more than ½ millimeter, it can't do direct healing. It might try to default back to secondary healing, but because the fixation is often too rigid for a good callus to form, you risk delayed union or even non-union. It's a trade-off.
Fascinating. Okay, what about nerves? Peripheral nerves? They can regenerate to some extent, unlike in the brain or spinal cord.
They can try, yes. If a nerve is cut cleanly, what we call neuromesis, the first thing that happens is degeneration. Distal to the cut, the axon and its myelin sheath just disintegrate. That's Wallerian degeneration.
And after Waller, okay.
And proximally, it degenerates back a short way, usually to the nearest node of Ranvier, another historical name drop there.
So the nerve fiber beyond the cut dies off. How does it regrow?
This is where the Schwann cells come in. They're support cells in peripheral nerves. First, they help call in macrophages to clear up all the debris from the degenerated axon and myelin.
Okay, clean up first.
Then the Schwann cells themselves multiply and line up, forming these crucial guidance tubes called the bands of Bungner.
Bands of Bungner, like little tunnels.
Exactly. They provide a physical and chemical pathway for the regenerating axon sprout from the proximal nerve stump to grow down.
And how does the axon know where to go? Does it just grow randomly?
No, it's guided. That's neutropism. The little growing tip of the axon, the growth cone, has receptors that respond to chemical signals, growth factors, hormones, matrix molecules released by the Schwann cells, and the target tissue further down. These signals basically coax it along the bands of Bungner towards its original destination, like a muscle or a patch of skin.
Amazing precision. But what happens if the nerve sheath, the outer layers, are badly damaged?
Ah, that's the danger. If the perineurium and epineurium are disrupted, or if there's a lot of inflammation and scarring, those regenerating axons can lose their way. They can sprout out randomly, get tangled up with scar tissue, and form a disorganized mass.
A neuroma.
A neuroma, often palpable as a lump, and frequently extremely painful because it's just a bundle of sensitive nerve endings trapped in scar, a real problem after nerve injury.
Right. Okay, one more specialized tissue. Tendons. Big challenge here because they need to be strong and glide smoothly, yeah.
Precisely. That's the conflict. If they just healed like skin with a big fibrous scar, they'd get stuck. So we think about two main healing mechanisms. The preferred one is intrinsic healing.
Intrinsic, meaning from the tendon itself.
Yes, cells within the tendon proliferate and repair the defect. They get their nutrients mostly from the tiny blood vessels within the tendon sheath, the vincula, and also from diffusion from the synovial fluid that lubricates the tendon. This tends to keep the healing contained within the tendon itself.
And the other mechanism, the less ideal one.
Extrinsic healing. This involves inflammation, and cells coming in from outside the tendon for the surrounding sheath and tissues. The problem is this process tends to lay down fibrous tissue between the tendon and its sheath.
Adhesions, scar tissue sticking everything together.
Exactly. And those adhesions stop the tendon from gliding smoothly. You get stiffness, loss of function.
So, managing tendon repairs after surgery must be tricky. You need to balance healing with movement.
It's a real tightrope walk, the management tension.
Yeah.
You need to start early active mobilization, carefully controlled movement, fairly soon after repair.
Why early? To break the adhesions?
Yes, to gently stretch and break those early, weak, extrinsic adhesions before they become dense and strong. This encourages the intrinsic healing pathway and maintains glide.
But the repair itself is still weak, right? Especially early on with that type 3 collagen.
Very weak. So while you're doing the mobilization, you absolutely have to protect the repair, usually with a splint that limits the range of motion to stop the tendon ends from pulling apart or rupturing completely.
Get the balance wrong, and you either get a stiff, stuck tendon or a ruptured one.
Precisely. It requires very careful protocols and patient compliance. Okay, so we've seen the ideal process, but things can go wrong. Healing can stall, or it can go into overdrive. Let's talk about the factors that mess things up and the kinds of problems we see.
First, what stops a wound from healing properly? What are the common roadblocks? The textbook lists local and systemic factors.
Right. Locally, near the wound itself, big problems are things like skin tension. If the edges are being pulled apart, it just promotes inflammation and stops closure.
Makes sense.
Hypoxia or ischemia is huge. Not enough oxygen. This could be from poor arterial supply or maybe venous congestion like in lymphedema. Healing cells need oxygen and nutrients.
And infection.
A massive factor. Contamination, established infection, or even foreign bodies left in the wound, they all create a hostile environment, keeping the inflammation going and preventing the shift proliferation. Oh, and radiotherapy damages local tissues and blood supply too.
Okay, those are local. What about systemic factors, things affecting the whole body?
Lots of those. Advancing age is one. Everything just slows down a bit. Obesity can impair healing, often due to poor blood supply and fat tissue. Malnutrition is critical. You need protein, vitamin C, zinc, etc. to build new tissue.
Smoking always comes up.
Always. Nicotine causes vasoconstriction, reducing blood flow and oxygen. Plus, other toxins in smoke impair cell function. Then there are major diseases. Diabetes mellitus is a big one, causes microvascular problems and impairs immune cell function. Connective tissue diseases can interfere, being immunocompromised like in AIDS or on immunosuppressant drugs. And finally, certain medication steroids are notorious for suppressing inflammation and healing, and chemotherapy drugs often affect rapidly dividing cells, including those involved in repair.
So a lot of potential spanners in the works. Now, what happens when healing goes too far? The abnormal scars. Hypertrophic versus keloid, this distinction is key, right?
Absolutely critical distinction. Both involve excess collagen deposition, usually because that inflammatory phase was prolonged or too intense, but they behave very differently.
Okay, tell us about hypertrophic scars.
Hypertrophic scars are raised, they can be red, firm, sometimes itchy, but the defining feature is they stay strictly within the boundaries of the original wound or incision. They don't invade the surrounding normal skin.
And they can get thinner on their own.
Often, yes. They tend to gradually regress, soften, and flatten over time, maybe a year or two. Under the microscope, their collagen is excessive, but still somewhat organized, often in parallel bundles. You tend to see them in areas of high skin tension, or after deep burns, or in wounds that took a long time to heal by themselves.
Right. Now, keloid scars. These are different beasts altogether.
Totally different. Keloids are pathologically exuberant. They aggressively grow beyond the original wound margins, invading the surrounding healthy skin, sometimes forming these claw-like extensions.
And they don't regress.
No, they don't regress spontaneously. They're often very itchy or even painful, and they are notoriously difficult to treat. They frequently recur even after excision. Histologically, the collagen is completely disorganized, thick, haphazard bundles.
What causes them? Are some people more prone?
There's a definite genetic predisposition. They're much more common in individuals with darker skin pigmentation. And frustratingly, they could be triggered by relatively minor trauma, things like ear piercings, vaccinations, insect bites, acne spots.
Wow. Okay, so that's abnormal scarring. What about the different ways we intentionally manage wound closure? Primary, secondary, tertiary healing.
Right. This classifies the surgeon's approach. Primary healing, or healing by first intention, is the goal for clean, uninfected wounds. You bring the edges together directly with sutures, staples, glue. Minimal tissue gap, minimal inflammation, fastest healing, best cosmetic result. That's the ideal.
Okay. Secondary healing.
That's when you deliberately leave the wound open. You do this if there's significant tissue loss or if it's heavily contaminated or infected. The wound has to heal from the bottom up.
How does it do that?
Through those processes we discussed. Granulation tissue fills the defect. Myofibroblasts contract the edges inwards. And finally, epithelial cells migrate across the surface. It works, but it's slow, involves much more inflammation and proliferation, and always results in a larger, often functionally poorer scar.
And the third option, kind of a halfway house.
Exactly. Tertiary healing, also called delayed primary closure. This is for wounds that are initially too contaminated or untidy to close safely right away, but you still want a better outcome than secondary intention.
So what do?
You debride the wound, maybe pack it loosely, leave it open for a few days, typically 4 to 7 days. Let the initial contamination clear, ensure there's no infection developing. Then, if it looks clean and healthy, you take the patient back to the operating room and formally close the wound surgically, like a primary closure.
Ah, so you delay the closure until conditions are optimal.
Precisely. It converts a contaminated wound situation into a cleaner one, significantly reducing the risk of infection compared to just closing it immediately when dirty.
Okay, we've talked about healing processes and types of closure. But in clinical practice, especially in surgery, describing a wound accurately is crucial, and you often need multiple systems, right? Not just one label.
That's absolutely right. No single system captures everything you need to know. You need to think about the cause, etiology, the depth, the level of contamination, how complex it is, whether it's acute or chronic. A good description often pulls from several classifications.
But perhaps the most widely used, especially for surgical planning and predicting infection risk, is the one based on bacterial contamination, the CDC system.
Yes, the U.S. Centers for Disease Prevention and Control classification. It's used everywhere. Its main purpose is to categorize the expected bacterial load in the surgical wound at the time of the operation. This helps predict the risk of surgical site infection, SSI.
It has 4 classes. Let's run through them. Class 1.
Class 1, clean. These are uninfected operative wounds. No inflammation encountered. Crucially, the respiratory, alimentary, GI, genital, or urinary tracts are not entered. Think elective hernia repair, breast surgery, orthopedic joint replacement. Lowest infection risk may be 1 to 2%.
Okay. Class 2.
Class 2, clean contaminated. Here, those tracts are entered, but under controlled conditions without unusual contamination. Examples would be an elective bowel resection with good technique and no spillage, or a routine cholecystectomy. Infection risk is a bit higher, say 3–8%.
Right, still relatively controlled. Class 3 is where it gets messier.
Class 3, contaminated. This category covers a few scenarios. Open, fresh, accidental wounds like a traumatic laceration you see in the emergency department soon after injury. Also, operations with major breaks in sterile technique or gross spillage from the GI tract. Or if you encounter acute non-purulent inflammation during the surgery, like acute appendicitis or cholecystitis. Risk goes up significantly here, maybe 10–15%.
And finally, Class 4, the worst category.
Class 4, dirty or infected. These wounds are already infected or heavily contaminated before you even start. Think old traumatic wounds with dead tissue, clinical infections like an abscess that you're draining, or perforated viscera like burst appendix, or diverticulitis with pus or fecal contamination in the abdomen. Infection risk here is very high, maybe 20–40% or even more.
That system is simple and widely adopted. But the source material points out a weakness. The definitions can be a bit vague.
Yeah, that's the downside. What exactly constitutes controlled conditions or a major break-in technique? It can be subjective. That leads to variability in how different surgeons or hospitals classify the same wound, what we call low inter-observer reliability. It's useful, but not perfectly precise.
So to get a more refined risk prediction, other tools were developed, like the NNIS score.
Exactly. The National Nosocomial Infections Surveillance Score, now often part of broader risk models, aim to give a more objective prediction of SSI risk by combining several factors.
It's a simple 0 to 3 score. What are the 3 things it looks at?
It looks at 3 independent risk factors, assigning 1 point for each, if present. First, the wound classification. Is it a Class 3 contaminated or Class 4 dirty wound? That accounts for the bacterial load.
Okay, 1 point if it's contaminated or dirty. What's the second factor?
The patient's overall health, using the American Society of Anesthesiologists, ASA score. If the patient has significant systemic disease, meaning an ASA score of 3 or higher, they get a point. This reflects their physiological ability to fight off infection.
Makes sense. Poor health, higher risk. And the third factor.
Duration of the operation. If the surgery takes significantly longer than expected, typically defined as longer than the 75th percentile for that specific type of procedure, they get a point.
Why does longer surgery increase risk?
More time means more tissue handling, potentially more blood loss, greater exposure to the operating room environment, maybe hypothermia, all things that can impair defenses and increase contamination.
So combining wound contamination, patient health, and procedure duration gives a more robust risk score than just the CDC class alone.
Yes, it provides a better stratification. A patient having clean surgery, class 1, but who is very unwell, ASA 4, and has a very long operation might actually have a higher SSI risk than a healthy patient, ASA 1, having a quick contaminated class 3 procedure. The NNIS score captures that nuance better. All right, let's shift from classifying wounds to actually managing them. This involves a systematic approach from assessment right through to closure.
And the first step, especially in trauma, is always the big picture, right? ATLS principles.
Absolutely. You always start with the Advanced Trauma Life Support Survey, airway, breathing, circulation. Address life-threatening injuries first. Only once the patient is stabilized do you focus on the specific wound and limb. And complex injuries, say an open fracture with soft tissue loss, often need a team approach from the get-go, ortho, plastics, vascular maybe.
Okay, patient stable. Now you examine the wound itself. What are you looking for?
Site, size, shape, depth. How contaminated does it look? Is there active bleeding? Any obvious deformities suggesting an underlying fracture? You need a detailed description.
And you have to connect the appearance to how the injury happened, the mechanism.
Critical important. A tiny skin puncture might seem trivial, but if it was from a high-pressure injection paint, grease, hydraulic fluid, it's a surgical emergency. That stuff tracks widely under the skin along tissue planes, causing massive inflammation and necrosis far beyond the entry point. The external wound completely underestimates the internal damage. Needs urgent exploration.
Good point. And before you numb the area up,
You must do the neurovascular assessment. Check motor function, check sensation, light touch pinprick in the distribution of nerves that might be injured, check capillary refill, check pulses if relevant. You have to document this before injecting local anesthetic, otherwise you lose that vital information.
essential baseline. Then, thinking about preventing complications, antibiotics and tetanus.
Yes. Prophylactic antibiotics are generally given for class 2, 3, and 4 wounds. Maybe for some class I cases if the risk of infection consequences is very high, like prosthetic implants.
In tetanus, always consider it.
Always. The need for tetanus prophylaxis depends on two things: the type of wound and the patient's immunization history. Some wounds are considered tetanus-prone: deep punctures, wounds with devitalized tissue, contamination with soil or manure.
So you need to know if the wound is high risk and if the patient's vaccinations are up to date.
Exactly. If it's a high-risk wound and they're not fully immunized or their status is unknown, they'll likely need both a tetanus toxoid booster and human tetanus immunoglobulin, HTEG, for immediate passive protection. There are clear guidelines and algorithms for this. #TEC-TEC2, debridement and irrigation.
Okay, assessment done, prophylaxis considered. Now, the cornerstone of managing dirty or contaminated wounds, debridement, removing dead tissue. Why is this so fundamentally important?
Because dead, devitalized tissue is the perfect food source for bacteria. It has no blood supply, so antibiotics can't reach it, and immune cells can't get in there to fight infection. It has to be removed for healing to occur and to prevent sepsis.
Surgical debridement is the main way, cutting it out.
It's the most common and often most effective way, especially for significant amounts of dead tissue. You excise tissue layer by layer until you reach healthy bleeding tissue.
But knowing when to stop must be difficult sometimes. How do you tell healthy from unhealthy?
It can be very challenging, especially with muscle or fascia. Healthy fat is typically soft and yellow. Healthy muscle should be reddish pink, bleed when cut, and ideally twitch or contract when stimulated, say with diathermy. Fascia should be white and glistening, but appearances can be deceiving, especially after blast injuries or severe contamination.
So sometimes you need to go back.
Often, yes. The concept of the second look operation is vital. You do an initial thorough debridement, maybe pack the wound, and plan to take the patient back to the operating theater 24-48 hours later for another look. Reassess viability, remove anything that has declared itself non-viable in the interim. Sometimes it takes multiple debridements to get a clean, stable wound bed ready for closure.
Makes sense. Are there other ways to debride besides sharp surgical excision?
Yes, several. Mechanical debridement can be as simple as vigorous irrigation, or using things like wet-to-dry dressings, although those can be painful and non-selective, pulling off healthy tissue too.
Okay.
Autolytic debridement uses the body's own enzymes. You facilitate this by applying moisture-retentive dressings, hydrocolloids, hydrogels. They keep the wound moist, allowing natural enzymes to slowly liquefy and break down the dead tissue. Good for smaller amounts of SLIV.
And you mentioned enzymes directly.
Yeah.
And even maggots.
Yep. Enzymatic debridement involves applying topical agents, like collagenase ointment that specifically target and break down necrotic tissue components. And biological debridement uses sterile, medical-grade larvae of the green bottlefly, Lucilia sericata.
Maggots? Really? How do they work?
They secrete powerful enzymes that selectively dissolve only the dead necrotic tissue, leaving healthy tissue unharmed. They also ingest bacteria and seem to stimulate granulation tissue, surprisingly effective for certain types of SLIV wounds.
Wow. But before any fancy debridement, the simplest first step is?
Irrigation, just washing out the wound, usually with copious amounts of warm, sterile, normal saline. It physically removes debris, reduces the bacterial count. Simple, but essential. The solution to pollution is dilution. Hashtag 3. Closure and reconstruction options. Okay, wound assessed, debrided, irrigated. Now we think about closing it. First, you need to be sure you know the full extent of the injury. Any damage to nerves, vessels, tendons, joints, bones needs identifying and repairing, but usually only once the wound is clean.
And repairing delicate structures like nerves or vessels needs special techniques.
Definitely. Often requires magnification, surgical loops, or even an operating microscope, and very fine instruments and sutures for microsurgical repair.
And when closing the skin, what's the absolute golden rule?
Closure must be without tension. If you have to pull hard to get the edges together, the sutures will cut through, the skin edges will become ischemic, it'll likely break down or heal with a wide, ugly scar. Tension is the enemy.
So how do you achieve a tension-free closure if there's a defect?
You close in layers, if possible. Deep layers, like fascia or deep dermis, can be closed with absorbable sutures to take the tension off the skin. Then the skin itself can be approximated gently with non-absorbable sutures, like nylon or staples, or maybe subcuticular sutures for a better cosmetic result.
And how long do skin sutures stay in? Varies by location.
Big variation. Highly vascular areas like the face heal quickly, sutures can come out in 5 days or so. Areas under more tension or with poorer blood supply, like the lower leg or back, need longer, maybe 10 to 14 days.
Right. But what if you just can't close it directly without tension? Too much tissue missing.
Then you have to move up the reconstructive ladder, or reconstructive elevator, as some call it now. This is a framework for choosing more complex closure methods. The basic options boil down to grafts versus flaps.
Okay, what's the fundamental difference between a skin graft and a flap?
Blood supply. A skin graft is a piece of skin, either split thickness, epidermis and a bit of dermis, or full thickness, epidermis and most of the dermis, that is completely detached from its own blood supply.
So how does it survive?
It has to pick up a new blood supply from the recipient wound bed. The bed must be clean and well vascularized. Initially, it survives by soaking up fluid like a sponge, inhibition. Then tiny vessels grow into it from the bed, inosculation. It's parasitic initially.
Okay, and a flap?
A flap is different. It's a unit of tissue, can be skin, fat, muscle, bone, or a combination, that is moved from a donor site to the defect while maintaining its own intrinsic blood supply.
So it brings its own plumbing with it?
Exactly. It doesn't rely on the recipient site's vascularity for immediate survival. The blood supply might be kept intact via a pedicle of tissue connecting it to the donor site, a pedicled flap, or, in the most complex cases, it's completely detached and moved to a distant site.
The free flap.
The free flap. Here, the flap's artery and vein are surgically disconnected, the tissue is transferred, and then those vessels have to be meticulously reconnected to recipient vessels near the defect using microvascular anastomosis under a microscope. Highly specialized work.
Incredible stuff. One more tool that's become really common in managing complex open wounds: negative pressure wound therapy. NTWT.
Yes, NPWT, or VAC therapy, vacuum-assisted closure, has been a game changer. It involves placing a special foam dressing in the wound, sealing it with an adhesive drape, and applying continuous or intermittent suction via a tube connected to a pump.
And what does that negative pressure actually do?
Several things. It physically draws the wound edges closer together, macrodeformation. It removes excess fluid and wound exudate, reducing edema. It stimulates blood flow and promotes the formation of granulation tissue, microdeformation. It helps create a closed, protected environment. It's often used as a bridge to definitive closure, getting the wound bed ready for a graft or flap.
Sounds versatile. Are there times you absolutely shouldn't use it? Contraindications?
Yes, very important ones. You must not use NPWT directly over exposed blood vessels or organs, risk of erosion and catastrophic bleeding. not over malignant tissue, as it could potentially encourage spread, not in the presence of untreated osteomyelitis, bone infection, not if there's significant necrotic tissue still present that needs debriding first, and generally not over unexplored fistulas, especially if they connect to the bowel. You have to know the contraindications. Okay, let's highlight a few specific, really high-risk acute wound scenarios that demand urgent attention. These are things you cannot afford to miss.
Right, the surgical emergencies. You mentioned bites earlier,
Oh.
especially the fight bite.
Yes. Any wound over the knuckle, the metacarpophalangeal MCP joint that happened during a punch, especially punching someone's mouth, has to be assumed to be a human bite until proven otherwise.
Why is that so dangerous?
Because human saliva is full of nasty bacteria, often a mix of aerobes and anaerobes. If that bacteria gets inoculated directly into the joint space, it causes septic arthritis. And joint infections are true surgical emergencies.
Why the urgency?
Because the pus and inflammatory enzymes rapidly destroy the articular cartilage, the smooth lining of the joint. Even a day's delay can lead to permanent joint damage, chronic pain, and stiffness. Any hot, swollen, exquisitely tender joint with pain on even slight passive movement needs immediate washout in the operating theater.
Got it. Fight bites, surgical emergency. What about degloving injuries? Sounds nasty.
They are nasty. A degloving injury happens when a shearing force literally rips the skin and subcutaneous fat off the underlying deep fascia and muscle, like pulling a glove off.
How does that usually happen?
Often high-energy trauma. Crush injuries, limbs caught in machinery, run over accidents by vehicles. Can be open, where the skin is torn off completely like a finger avulsion, or it can be closed, where the skin surface remains largely intact, but is completely detached underneath.
And the closed ones are particularly treacherous.
Yes, because the extent of the damage is hidden. You might just see bruising, but underneath, there's a huge potential space filled with blood and lymphatic fluid, and the overlying skin flap has lost its blood supply from the deep perforating vessels. It's often much larger than it looks.
Is there a specific name for that closed type?
A classic example is the Morel-Lavallée lesion, typically described over the greater trochanter, the bony prominence on the side of the hip, after a fall or impact, but can happen elsewhere. It's that collection of blood and lymph in the potential space created by the shearing. Needs drainage and often debridement of the overlying fat, as the skin flap viability is compromised.
How do you assess if the degloved skin is going to survive?
It's difficult. Often requires serial debridements in theater. You look for signs of viability like punctate dermal bleeding when you cut the edge. Sometimes specialized techniques like injecting intravenous fluorescein dye and looking under UV light or indocyanine green fluorescence angiography can help map out the perfused areas. Management depends on the pattern and extent. Sometimes the skin can be sutured back down, sometimes it needs excision and grafting. Some classifications exist to guide this.
Okay, another emergency, acute compartment syndrome, ACS. This is about pressure buildup, right?
Exactly. It's when the pressure inside a closed, rigid fascial compartment like those in the lower leg or forearm rises so high that it cuts off the blood supply to the muscles and nerves within that compartment.
What causes the pressure to rise?
Most commonly, bleeding or swelling after a fracture, even a closed one. Also, severe soft tissue crush injuries, burns that cause circumferential swelling, or even just prolonged compression of a limb, like someone found unconscious lying on their arm.
And the key symptom you absolutely cannot ignore.
Pain out of proportion to the apparent injury. Severe, deep, aching, worsening pain. And critically, pain that is significantly worse when you passively stretch the muscles in the affected compartment. That stretch pain is a highly sensitive sign.
What about other signs? Numbness? Pulses?
Paresthesia, numbness, or tingling is an early and very important sign of nerve compression. But you need to remember, absent pulses are usually a late sign in ACS, or they might indicate a separate major arterial injury higher up. Don't rely on pulses being present to rule out compartment syndrome. The microvascular circulation gets shut down long before the main artery does.
So high index of suspicion based on pain and stretch pain. How do you confirm it and decide to operate?
Diagnosis is primarily clinical. If you suspect it, you should act. Measuring the intercompartment pressures, ICPs, directly with a needle and pressure monitor can be helpful, especially in patients who can't communicate reliably, unconscious, intubated regional anesthesia.
Is there a pressure threshold for surgery?
Yes. The most common guideline is based on the difference between the patient's diastolic blood pressure, DDP, and the measured ICP. If that difference, the delta pressure, DBP-ICP, is less than or equal to 30 millimole Hg, it's generally considered an indication for urgent fasciotomy. Some use an absolute ICP threshold, like 30 or 40 millimilli HG, but the delta pressure is often preferred as it accounts for the patient's perfusion pressure.
And fasciotomy means?
Surgically releasing the pressure by making long incisions through both the skin and the tight, inelastic deep fascia overlying the affected compartments. For the lower leg, this usually requires 2 long incisions, one medially to release the posterior compartments, and one laterally to release the anterior and peroneal compartments to ensure all 4 are decompressed. The wounds are typically left open initially.
A limb-saving procedure. Delay is disastrous.
Absolutely. Irreversible muscle death can start within 4-6 hours of ischemia. Delay leads to necrosis, contractures, nerve damage, potential need for amputation, and systemic complications like rhabdomyolysis and kidney failure. Time is muscle.
Okay, one more really scary one. Necrotizing fasciitis, NF, the flesh-eating bacteria infection.
It's devastating. A rapidly spreading infection primarily involving the deep fascia, but often destroying overlying skin and underlying muscle too. Mortality rates are still shockingly high, up to 25–30% even with modern treatment.
What causes it? Is it always that group A strep?
Often it's polymicrobial, a mix of different bacteria working together. But type 2 NF, caused by monomicrobial infection, usually Streptococcus pyogenes, group A strep, is the classic flesh-eating form and can be particularly aggressive. Other common culprits include Staphylococcus aureus, including MRSA, and various gram-negatives like E. coli.
How does it present? What are the red flags?
The key is often pain that seems way out of proportion to the visible skin changes, which might initially look like just cellulitis. The patient is often systemically very unwell, toxic, septic shock, multi-organ failure developing rapidly.
Any specific skin signs to look for?
As it progresses, you might see skin changes, like dusky discoloration, blistering, or bullae formation, maybe crepitus, a quackling sensation under the skin due to subcutaneous gas produced by bacteria. But the truly pathognomonic sign, if you see drainage, is dishwater pus, a thin, grayish, often foul-smelling discharge. That strongly suggests deep fascial necrosis.
So, like ACS, this is mainly a clinical diagnosis. Don't wait for tests.
Absolutely not. Delay is fatal. While scoring systems like the L-Rhinox score exist, they should never delay surgical intervention if your clinical suspicion is high. Treatment has 2 immediate pillars: high-dose, broad-spectrum intravenous antibiotics, and urgent radical surgical debridement.
Radical debridement, meaning very aggressive.
Extremely aggressive. You have to open the affected area widely and excise all necrotic fascia, skin, fat, and muscle until you're back to healthy, bleeding tissue. This often involves huge resections. And because the infection spreads so rapidly along fascial planes, you almost always need to plan for a second-look operation 24–48 hours later to ensure you got it all and to debride any further tissue that has died off.
We've covered acute healing and emergencies. Let's finish by looking at the other end of the spectrum. When healing fails long-term chronic wounds and how we manage the end result, the scar.
Right. A chronic wound is basically one that gets stuck. It fails to proceed through the normal healing phases in an orderly and timely way, often stuck in a prolonged dysfunctional inflammatory state.
What keeps it stuck there?
Usually a combination of factors. Persistent infection, often with bacteria forming resistant biofilms, poor blood supply, ischemia, repeated trauma, underlying systemic illness like uncontrolled diabetes, cellular senescence. The cells just get old and stop responding properly.
So managing them involves addressing those underlying issues.
Exactly. You need meticulous debridement to remove the necrotic tissue and biofilm, aggressive infection control, managing inflammation, and, critically, managing moisture balance. Chronic wounds are often too wet or too dry, so choosing the right advanced dressing is key to create an optimal healing environment.
A big category here is leg ulcers. What defines an ulcer, and what's the crucial thing to remember about non-healing ones?
An ulcer is simply a break in the continuity of an epithelial surface. Leg ulcers can have many causes: venous insufficiency, most common, arterial disease, diabetes, neuropathic, trauma, infection, autoimmune diseases, even sometimes cancer.
Cancer in an ulcer.
Yes, this is the critical point. Any chronic ulcer, especially one that's been present for months or years and isn't responding to good standard treatment, must be biopsied. You have to rule out malignant transformation.
What kind of cancer?
Most commonly, a squamous cell carcinoma arising within the chronic wound or scar. This has a specific name: Marjolins ulcer. Always keep in the back of your mind for non-healing chronic wounds.
Important pearl. Okay, another type of chronic wound, often preventable, pressure injuries. Previously called pressure ulcers or bed sores.
Yes, the terminology shifted to pressure injury. to emphasize that damage can occur even before the skin breaks down and to include injuries caused by medical devices, not just bony prominences.
Where do they typically occur?
Over bony bits where pressure is concentrated at the sacrum, heels, hips, trochanters, elbows. Anywhere prolonged pressure cuts off blood supply to the skin and underlying tissue.
There's a staging system for these, isn't there?
Yes, it's fundamental for describing the severity and guiding treatment. Stage 1. Intact skin, but with non-blanchable redness, the first sign of trouble. Stage 2. Partial thickness skin loss, like an abrasion or blister involving the epidermis and maybe part of the dermis. Stage 3. Full thickness skin loss. Subcutaneous fat is visible but not muscle or bone. Stage 4. Full thickness skin and tissue loss. Muscle, tendon, or bone is exposed. There are also categories for unstageable, where the base is covered by slough or eschar so you can't see the depth, and deep tissue injury, intact skin that looks bruised, purple, or maroon, suggesting deep damage underneath.
And the key message with pressure injuries is prevention.
Absolutely. They're largely considered preventable events. Risk assessment using validated scales like Braden or Waterlow is standard practice in hospitals and care homes. Prevention strategies focus on meticulous repositioning of immobile patients, turning every 2-4 hours or even more frequently, using specialized pressure redistributing surfaces, mattresses, cushions, optimizing nutrition, and managing skin moisture.
And treatment, if they do occur. Is surgery common?
Surgery is usually not the first line. Treatment focuses on offloading pressure, managing wound care, debridement, dressings, optimizing the patient's overall health, nutrition, controlling diabetes, etc. Surgical reconstruction, usually with flaps rather than grafts because you need robust vascularized tissue, is reserved for deep, non-healing, stage 3 or 4 injuries, typically only after conservative measures have failed, and crucially, only if the patient and their support system can reliably comply with the intensive postoperative care and prevention strategies to stop it recurring.
Right. Surgery is a big undertaking for these patients. Okay, finally, let's talk about managing the end result of healing, the scar itself.
Even a well-healed wound leaves a scar, and that scar goes through a maturation process. Initially, for the first year or even 2, it's an immature scar, often raised, red or pink, firm, sometimes itchy. Over time, it should mature into a pale, softer, flatter scar. But remember that 80% strength limit.
So can you influence how well a scar matures? Does prevention start with the surgery itself?
Definitely. The best scar management is prevention. Good surgical technique is key. Placing incisions along relaxed skin tension lines where possible, handling tissues gently, meticulous layered closure without tension, making sure the wound is properly cleaned initially prevents traumatic tattooing where dirt gets trapped into the healing skin, leaving a permanent gray or blue mark.
Okay, but what if you do start developing a raised problematic scar, like a hypertrophic or early keloid? What's the first-line treatment?
Generally, silicone gel sheeting or topical silicone gel, applied consistently for several months. The exact mechanism isn't perfectly understood, but it seems to increase hydration and possibly temperature at the scar surface, which helps normalize collagen production by the fibroblasts. It can soften, flatten, and reduce redness and itching.
And if silicone isn't enough?
Then you move to more advanced options. Intralesional corticosteroid injections, usually triamcinolone and acetonide, injected directly into the scar tissue. This reduces inflammation and inhibits collagen synthesis, often needs multiple sessions. For resistant keloids, options get more complex, involving things like cryotherapy, freezing, laser therapy, or surgical excision, combined with adjuvant treatments like radiotherapy or injections of drugs like 5-fluorouracil, 5-FU, immediately after, because keloids have such a high recurrence rate after simple excision alone. There are detailed algorithms for managing these difficult scars.
Right. Lastly, scar contractures. These are functionally devastating, aren't they?
They can be. A scar contracture occurs when a scar, especially one crossing a joint or concave area like the neck or palm, tightens and shortens excessively during maturation, pulling the surrounding tissues together and restricting movement. Can cause severe functional and cosmetic problems.
How do you fix a contracture? Just cut the scar.
Simply cutting it, scar release, often isn't enough, as it tends to reform. The principle is to release the tension and replace the tight scar tissue with healthy, pliable tissue.
Flaps again.
Often, yes. Local flaps are very useful. The classic example is a Z-Plasty. This involves making a Z-shaped incision, centered on the scar line, creating 2 triangular flaps, and then transposing them. This cleverly lengthens the original scar line and changes its direction, relieving the tension. Multiple Z-Plasties can be used for longer contractures.
Why are flaps preferred over grafts here?
Because skin grafts, especially split-thickness grafts, have an inherent tendency to contract themselves as they heal. Using a graft to fill the defect after releasing a contracture often leads to the contracture recurring. Flaps bring in tissue that is less prone to the secondary contraction. If a graft is absolutely necessary, a full-thickness graft is generally preferred over a split-thickness one, as it contains more dermis and tends to contract less, providing a better functional and cosmetic outcome, although the donor site is more limited. Hashtag outro.
Wow. Okay, that was a comprehensive journey. We started with the very first moments of injury, the hemostasis and inflammation cascades, then explored the specific ways bone and nerves try to repair themselves.
We dissected the clinical classification systems, the CDC classes, the NNIS score, understanding how we categorize risk, and then we hit the critical management principles, debridement, irrigation, closure options, from simple sutures up to free flax.
And covered those acute emergencies, the fight bites, degloving injuries, compartment syndrome, necrotizing fasciitis, where rapid recognition and action are paramount. Finally, tackling chronic wounds and the long-term challenges of scar management and contractures.
I think the core takeaway for you, as a learner or practitioner, is that wound healing isn't just something that happens passively. It's an active, complex, and often delicate biological process. Your clinical decisions really depend on understanding these underlying mechanisms.
Knowing that 80% strength limit, knowing the difference between intrinsic and extrinsic tendon healing, knowing why a keloid behaves differently from a hypertrophic scar, these details matter.
They dictate treatment, prognosis, everything.
We started this deep dive by noting that striking difference between adult healing, which defaults to fibrosis and scarring, and fetal healing, which can achieve true regeneration.
Which really makes you think, is the scar truly the best we can do, or is it, as we said, maybe a failure to sustain that regenerative drive?
So here's a final thought to leave you with. If the critical difference lies somewhere in that transition from inflammation to remodeling, maybe it's about controlling macrophage behavior or managing the collagen type switch more effectively. If we could just tweak those signals, even slightly, to push adult healing closer to that fetal model.
Think about the impact. What percentage of the global disease burden linked to fibrosis, not just skin scars, but fibrotic diseases in the lungs, liver, heart, kidneys, could potentially be reduced or even eliminated? It suggests the ultimate goal of regenerative medicine might not just be about building new parts from scratch, but about unlocking and perfecting the body's own fundamental repair processes that we witness, albeit imperfectly, every single day.
A powerful thought. Thanks for joining us on the deep dive.